Our next speaker is Goldy. Goldy is a senior social worker in Hadassa, and she coordinates the social service in the pediatrics and maternity units. And she will talk with us about the psychosocial aspects of genetic testing. Thank you, Goldy. I'll just...
Genetic impact. Now that I know, who do I tell and how do I tell? I feel a little silly standing here after we've heard about the ethics, after we've heard about the genes. I'm a social worker. I'm not an ethicist. I'm not a geneticist. I'm a social worker. For the last 7 years, I've been working in the clinical genetics department with the people who are running this evening, with Professor Miner, who's sitting here in our audience. And I'd like to talk to you a little bit about the psychosocial implications of the genetic diagnosis. What is the process that begins when a person decides to explore his or her own genetics? How do they feel? How are they affected? What decisions are they faced with? Who must they share this information with, which we've been hearing about again and again tonight? And is genetic information a life-changing experience? Okay. So genetic impact, what does it mean? We've talked about profit tonight. We've talked about prenatal tests. Okay, so it's 2015. How do you and I make use of technology? Let's look at the different situations that involve asking the questions: genetic counseling and testing, genetic questions, genetic answers, genetic diagnosis. Among them, a lot tonight about BRCA, the breast cancer gene. It affects both men and women. I'd like to talk a little bit about chronic illnesses like celiac and diabetes. We haven't talked about that really tonight, in both children and in adults. I would like to address this as some of the issues parents face with children who are developmentally delayed, and I will touch on issues of adults. Huntington's, we've talked about that quite a bit tonight. The late onset disease, it's one of many. The genetic impact is not only medical. It can affect the entire family, the individual medically, emotionally, and socially. The psychosocial response is different in each individual, and there are many emotional responses that occur in these situations. So, why do people turn to genetic counseling? Sometimes they're faced with a threat of illness. Sometimes they're already ill. For some of us, doing is helpful. For some of us, not doing is helpful. Whether it's our own illness or someone we care about, we want and we need answers. We're always asking questions, hoping for the healthiest, happiest, best possible answer. Sometimes, like during a pregnancy, we may be following medical advice. We ask for genetic counseling. Frequently, we need to make decisions that are both cognitive and emotional. We ask in order to be better informed. Our coping behaviors are focused on dealing with or avoiding dealing with. Each of us responds in ways that are most comfortable for us. We are searching for ways to alleviate distress. BRCA testing is a simple test. In fact, many of you may know someone who has already been tested. You may have given thought to being tested yourself. In the recent past in Jerusalem, there were signs in many doctors' offices saying that there's a BRCA research project and suggesting that patients be tested to advance the research. In one hospital in the city, as you walked into the lobby, maybe to visit someone who had just had a baby, you may have been approached and asked if you would participate in testing. For some people, this was their first contact with genetics. Others may have decided to test because of their family history. Their physician may have an increased awareness and may have had a policy to send people for testing. So now what happens? All of us have had different types of tests, blood tests, other tests. We wait for the answer. Waiting makes us nervous. It makes us anxious. We hope, we anticipate that we will get the right answer, that we are not carriers, that we will not be ill. In 2015, we surf the internet. We look for information. We gather knowledge, whether by talking to people, by visiting genetic counselors, by going to our doctors. We focus on being ready to hear the news. And when we do hear it, if we are told we are a carrier, How are we? How do we feel? What is our response? Will this be the day that changes our lives? How do we alleviate our distress, and how do we proceed? Who do we choose to tell? A visit with a social worker is a safe place to discuss all of these feelings, to understand that after a diagnosis, you need not be alone, to find an accepting place where you can explore your options, who to tell, how to tell. Psychosocial support facilitates your accepting your situation, making a plan of priorities, moving forward, deciding whom you must share this news with, either for your own support or for their health needs. We've talked about that a lot. Okay. When we get to prenatal tests, genetics impacts us many times in the course of our lives. Couples may go for genetic testing before they decide to get married. This is Jerusalem. In the ultra-Orthodox world, there's an organization called Dor Yesharim. Dor Yesharim tests older teenagers, assigning each one a number. When the time comes for the matchmaker to get to work, she asks, can 150 marry number 300? And she gets an answer, yes or no. Kupat Cholim, the health funds, offer couples genetic testing, and physicians refer their pregnant clients to geneticists, whether in Hadassa or in other places. During the happiest of times, an anticipated and eagerly awaited pregnancy, there is stress, and often there is distress involved in receiving the diagnosis. There may have been a problem in the ultrasound. There may be a family history that would indicate testing is a wise idea. Future mothers whose task up until now has been to protect their health and to protect their babies are now given information and may be forced to make decisions. If the genetic test reveals an illness, the family will receive information for planning their future. Does it mean stopping the pregnancy? Does it mean preparing for the pregnancy? We see people who come from all over the country because their fetuses have been diagnosed with all kinds of issues, and they come to have their babies where they can be treated immediately upon birth. Doesn't always mean stopping a pregnancy. I've mentioned Dor Yesharim. They test for illnesses that require both parents to be carriers. They do not test for conditions where only one parent needs to be a carrier. Fragile X only needs the mother. And Fragile X causes cognitive developmental delay. So when does a family test for Fragile X? And why does this feel different than all the other situations? And working with a family who had several healthy children and then a child who was severely delayed, when the child was tested and Fragile X was the diagnosis, mom was pregnant. So what happens? Then she has to decide, is she going to do amniocentesis or not? Does she want to know if the baby she's carrying will also be affected? Her husband was very supportive of her. Both were very relieved to find out that the child she was carrying was healthy. But now how did she feel? She spoke about terrible guilt feelings she was experiencing. She had caused her son's problem in her mind. How could she share this information with her sisters? How could she not? What if they were also carriers and did not know? We discussed how she felt about non-disclosure and the possible birth of additional affected nephews. We discussed responsibility, that knowledge that she has belongs to them as well. You've talked about that quite a lot. But she asked, how do I tell? Counselors, physicians, social workers, we gain practice and are taught about delivering unwanted news, but our patients are not trained in the same way. This patient spoke about her large family, what was happening in each sister's life. One did not have a very strong marriage, and she was afraid that this news would destroy the relationship. How do I tell, she asked again and again. How do I tell? And so one of the things that happens when people come for genetic counseling is we break the bad news, and then we ask them to do the same. They haven't been trained to do that, and they don't know how. We're asking an awful lot. chronic illness, well, I've talked about BRCA a little bit, about prenatal testing, about Fragile X, but the world in genetics includes so much more. There are many familial illnesses, and I won't speak about most of them. I'm a social worker. I would like to raise the issue of celiac. It is a medical condition. The diagnostic process begins with children or adults who do not feel well. They begin exploring the root cause of their illness. They go from their general practitioner or pediatrician to their gastroenterologist. They come to the geneticist. Testing begins. Blood tests, biopsies, genetic tests. Once one person in the family has been diagnosed, more frequently, other people in the family may be diagnosed. Other people may be affected, and once they understand the illness, they look around and they see who else they have in their family. Diabetes is similar, a diagnosis and a familiar disease. But as much as these are medical conditions, there are psychosocial aspects to them as well. Is the patient embarrassed by his disease? Do they consider it a form of a disability? They wonder how their social life will be affected. Do they tell their friends? Do they tell their families? Will my friends still invite me for dinner? Will they effortlessly prepare special food that I need? Will they tell me to bring my own food? Will they tell me to stay home? Do I feel responsible for doing this to my children or to my grandchildren? Do I have a desire to change the world that will accommodate them and to educate the world? Am I constantly apologizing for giving my friends extra work if I have diabetes? Do I feel guilty for passing this along? How can a social worker be of assistance in these situations? Different families work out different ways that are appropriate for them. And within a family, between the parents, there may be differences of opinion on how to deal with telling or keeping secrets. Normalizing a less than normal lifelong situation or feeling as if each day is a challenge. Social workers listen to each person in the room. I try to help them hear each other so they can absorb what their partners are feeling. We do not choose our genetic inheritance. We've talked a lot about Huntington's. I want to look at it from the psychosocial perspective. I became familiar with it only after I started working in the genetics clinic. Late onset. Okay, we heard about that quite a lot tonight. It's very debilitating. It's life-threatening. I'd like to tell you about 3 generations. I never met the grandfather. He had already passed away. But he had been diagnosed as being ill with Huntington's. As we've heard, his children each had a 50% chance of becoming ill. In other words, they had a 50% chance of staying healthy. Coming into our clinic was a married couple. The husband was the son of this grandfather. The wife wanted to know if she became pregnant, would she be passing on this gene to a child? We can easily test for that, right, Annika? Okay. The husband didn't want to know. He did not want to know if he would become ill in another 15 years. He didn't want to know if he was going to become ill next week. So life is not so simple. The husband did not agree to be tested. If he is healthy, so be it. And if he is not, he does not want his future clouded with an illness that might be awaiting him. And so it continued. They could not agree. So who is the patient? Is the patient in the room? Frequently, parents come for genetic diagnosis for their child. The child will be with them to be examined by one of our clinic's physicians. Will the child be hearing the diagnosis from us? We keep talking about children, but we didn't talk about the ages of the children. And I think there's a significant difference if we're talking about a 3-year-old or a 5-year-old or a 15-year-old or an 18-year-old. Not that long ago, one of our physicians asked that I join him in meeting with parents. Because of treatment for one medical condition, a discovery was made that was going to affect this teenage boy when he became an adult. He was not in the room for this discussion. He didn't even know his parents had come back to the hospital. We discussed this child's future. We discussed when and how to tell him. We discussed how in sharing with him, his self-image would probably be affected for the rest of his life. And we discussed who would be the best person to tell him. So when we look at Fragile X and BRCA, it's clear that the information of status can affect a wide range of relatives, whether it's parents, siblings, children, and cousins. Many of the people who may be affected, our patients, are very close to these relatives. But with some, as Annika mentioned, they have a much more difficult relationship or distant tie. When it's parents of a child, you can't get closer than that. When they have to worry about how to tell their son information that will affect him for the rest of his life, you can't get heavier than that. We've offered to do the explaining for them. It's the least we can do. So, how does it feel to receive a diagnosis? What are we telling them? What are they hearing? What do they have to tell others? What are they thinking? And do they really know enough and understand enough to inform anyone? Responsibility, we can generalize and say that the person who has come for genetic counseling is part of a family system. That's a big social work. When taking a history, information is gathered about grandparents, parents, siblings, cousins, children. This enlarged group is not in the room with us. The information being given affects them as well. And so responsibility, we've been asking that again and again. Am I responsible to share with them? Do I feel guilty for being diagnosed with something that may affect others as well? Maybe this is where Jewish guilt comes from. The patient is concerned for their own well-being and their own health, and for those they feel the closest to emotionally. We encourage them to notify all. They fear for themselves. They fear for how they will be perceived. They fear for having passed along an illness to loved ones. Carrier status, that just changes everything. Does the carrier think differently of herself? A young woman came to the clinic with her partner. Her mom was in a wheelchair. She asked to be tested for the genetic illness her mother had, a late onset disease. Both her aunt and her you remember, don't you, Marty? Both her aunt and her grandmother had become wheelchair bound. There are many opinions on whether to encourage or discourage this testing for this knowledge. Why know now if you have it or you don't, when you won't be affected for 30 years? But our patient stressed that she wanted to plan her life. She said, I want to know. I need to know. And so, does she really understand enough to be told? It's a little paternalistic, isn't it? She needs to know what to make as a priority in her life. And so while there are no guarantees of what else may happen and affect the rest of her life, knowledge is a form of empowerment. It can affect how the individual and the family perceive themselves. Knowledge provides options, and it helps the individual make choices. So one of the things that, one second, okay. One of the things that is taught in medical schools all over the world, spikes. Spikes is shorthand for a method of delivering bad news. In Hadasah Medical School, social workers team up with physicians to teach spikes to medical students. Doctors all use it, and I'd like to explain a little bit about it for those who may not know. It's not a formula. You don't get to plug in a few words into pre-existing sentences. It's about a setting, the S is for setting, preparing a room to meet with people, not to talk to them in a hallway, understanding the information that you need to convey, and making sure that they are with you. It's a place for everyone to sit, for whomever they want to bring with them into the room, whether they want to bring their uncle or their neighbor or their friend who's a pediatrician. They get to decide who comes with them. Perception, we ask, what does the patient know about what we're about to tell them? What are we meeting? And what are we going to discuss? The I is for invitation and spikes. We ask if they're ready for us to discuss the results of the tests. Are they ready to hear what we know? Knowledge, the geneticist will say, I have to tell you the results of this test. I'm sorry if it's not what you want to hear. And then, in very understandable words, explain the information. The diagnosis can be the same. The geneticist can be the same. Depending on who's sitting on the other side of the desk, the conversation can be completely different. E is for empathy, because we understand what the patient is feeling. We see it on their face. We've seen it before. It's understandable that what we're about to tell them is going to be very, very upsetting. And the most important is the last S, strategy and summary. Don't leave the room until you know what's happening next. Let us help you build a plan. Let's work this out together. We always offer to speak to them again, to answer more questions that may arise, to notify their treating physician for them, and to provide them with counseling when they feel the need. And so sitting in this room, we're all individuals made up of connections with others. Information that we may get about ourselves can change how we feel about ourselves, can change how our families manage their lives. Pure scientific information, a genetic diagnosis, is surrounded by the psychosocial effect it has on us and on our loved ones. For most of the things we've heard tonight, there are support groups, there are internet sites. Today, people go online and join support groups all over the world and in any language. There is every reason to ask for help. There is every reason to receive support. There's no reason to deal with genetic problems alone. Thank you.